All right, good afternoon and welcome to this uh, episode of our Harvesting Solutions webinar series. Uh, Thank you for joining us. And as you may or may not know, we have started this webinar series as a way for our Farm Bureau members to talk about issues and challenges that are facing Minnesotans across the entire state. We know that the strength of Farm Bureau lies in our members identifying and addressing these issues and then working to find solutions that can impact all of the local communities across our state. So we hope that today we will be able to talk about healthcare across Minnesota and what we can do as Farm Bureau members to really make a difference. So we are very excited today for our speaker, Dr. Ken Holmen. He's the president and chief executive officer of CentraCare. And he told me I didn't need to do much of an introduction, that he would do that for him. But I just want to point out that he got his MD at the University of Minnesota Medical School. And so I have to always put a shout out for the Gophers there. So Dr. Holmen, please take it away.
Thank you very much, Pam. And I tend to be informal. And so can we quickly run around the room and have everybody introduce themselves and where they live and kind of what they do? I'm presuming most of them are farmers or implement dealers, but let's run around the room real quick so I have some context of who's participating today. Is that okay?
Yeah, that would be great.
I'm Roger Sauerbrei from Carver County, president of Carver County Farm Bureau.
So I'm Jim Checkle. I just recently retired from working in a research lab at Mayo Clinic. I'm the Dodge County Farm Bureau president, and I serve on an advisory board for Mayo for rural health care.
Sure. Okay.
I'm Dave Johnson. I am the Director of Operations for the Minnesota Farm Bureau.
Hi, I'm Rachel Peterson. I am our leadership coordinator at Minnesota Farm Bureau, and I live in Northfield, Minnesota.
Mm-hmm.
Dennis Sable. I am membership marketing specialist working with 11 county farm bureaus in East Central Minnesota.
I am Rachel Riesig, Director of Communications for the Minnesota Farm Bureau, and I reside in Eagan.
I'm Virginia Major. I'm a membership and marketing specialist down in Southeast Minnesota and live in Zumbro Falls, Minnesota.
Hi, everybody. I'm Jessica Blossberg. I work with Minnesota Agriculture in the classroom, and I'm located in Lino Lakes, Minnesota, but I work with educators across the Twin Cities and kind of central Minnesota area. I believe Anne Marie, our executive director, will be joining us as well. I know she was in another meeting just before this.
Well, I think I will then start, Pam. First of all, thank you for the opportunity. The Farm Bureau is close to my heart. My dad's family, farmers from Comfrey, Minnesota. He lived on the Cottonwood side. My mom's family are, and as you know, Comfrey has a population of 260, 280, something like that. And my mom's family is from Thompson, Iowa, population of about 195. I grew up in Forest City, Iowa. I ended up a local businessman took an interest in my career. I am 72. A local businessman took an interest in my career when I was in high school and paid for a number of years of my education, which enabled me to kind of end up talking to you folks today. My daughter-in-law and her husband are John Deere folks, and I consider myself an amateur farmer. I have 10 acres. And my stress reliever is to, as I call it, putzing. And so I grew up with red. One of the challenges of my adult life is to become green. I have done that somewhat reluctantly, but that's okay, because you know, Catholics and Lutherans are marrying nowadays, so I guess it's okay if I switch to green. So I think as a conversation point today, healthcare in rural Minnesota, and my comments will be relatable to the rest of America. Coming out of the pandemic, our board, the CentraCare board, we have 10 hospitals. We serve roughly 750,000 Minnesotans in 43 counties. our board coming out of the pandemic said, what should our focus be for the next 10 years or so? So we landed on this theme called making rural life healthier. And I'm going to spend a minute on each word. So making is an action verb. As my dad frequently said, admiring a problem does not make it go away. And so making assumes a sense of accountability by us as board members, as communities, as leaders, as employees, to address the issues that our patients and customers and communities are feeling. Rural, some people don't like the word rural. We do. It sends us a message that we're in this together. Some people like outstate, some people like greater. We happen to land on the word rural. Granted, some cities are no longer perhaps viewed as rural, like for example, St. Cloud or even Rochester. But on the other hand, we are aggregators by using the word rural. And life is meant to not just talk about activities that we do in our communities related to our clinics and hospitals. As you know, life is rich. It involves certainly physical health, but it involves mental health, spiritual health, economic health, and all the things that we consider unique to our place in our community. And so the commitment of our board and our folks is to work on all aspects of life. And healthier, of course, means that we're on a journey. How do we get healthier? So making rural life healthier was adopted as a 10-year plan. And what I'm going to describe in the next short bit will be some of our major initiatives. I'm going to speak from a fairly high-level perspective, but I suspect that my points will be easily translatable to the communities and the folks that you serve. So one major initiative is workforce. We all recognize the significant issues around workforce shortages. They are present in every industry segment in America. This should not be a surprise to anyone. Several major demographic changes have occurred in the last number of years. We now have more people over the age of 65 in America than under 18. And that has two problems. One is as a population in American ages and as healthcare is able to do more, the demand has increased. And people are living longer. The demand has increased. And then we're short the younger folks to come into the workforce to help us take care of this. So a second demographic issue is the birth rate continues to fall in America. The birth rate is 1.7 to 1.8, which is below replacement value of 2. And so there's not a quick solution to our workforce challenges. And the third issue related to the demographic issue is how that changes the economic structure of healthcare. 70% of our revenue comes from a government source, a Medicare, Medicaid, whether it's a state or a federal program. And as you know, those sources of revenue are subjected to political pressure. And one of the challenges we have is that in general, government reimbursement for services does not cover our cost. We all recognize healthcare is too expensive, but in the current environment does not cover our cost. Number two is that more and more of our revenue is coming from government sources. And the third is the overall structure of government payments. When Medicare and Medicaid were set up shortly before World War II and accelerated after World War II, they used economists, of course, from Harvard, to set up some guidelines related to how we fund Medicare and Medicaid. And it was based on a worker to retiree ratio of somewhere greater than 4.6. In other words, 4.6 workers for a retired person yielded enough tax revenue to fund Medicare and Medicaid and the social infrastructure programs in America without threatening a cliff or recognizing that Medicare, Medicaid, or Social Security would go bankrupt. Of course, with an aging America, that ratio has changed. It's now below 3. And so the economic basis for how we provide resources to those in need, whether it's the seniors or some other segment of our population, has been threatened. And so the political nature of the funding has become a challenging conversation. So what is CentraCare doing about workforce? Number one, we need to do a better job, and this is true for all of our rural communities, of recruiting and retaining folks. How do we make our communities warm and welcoming? And I would go back to when many of our communities were formed in the late 1800s, early 1900s with our immigrant populations, and the sense of optimism and excitement that they had for folks to move to your community and be a part of the community. So we need to really, together with parts of Main Street, our churches, our schools, recruit and retain to get, it's not just a healthcare issue, it's all of our issue. The second thing is how do we give an opportunity for someone to stay in our community who may have 3 or 4 or 5 or 6 different jobs over their career. The younger generations, the average length that they will spend on the job is 6 to 7 years. And I suspect for many of you on the call, your perspective might be different than that. So how do we have folks in our communities recognize I may do this role for 6 years or 7 years, but I can find another role that offers me advancement or whatever interests me and stay in my town because we need our people. So ongoing training and career opportunity development is crucial. And I'm going to spend a little bit more time on education. I will use a specific example, but it is relevant for all educational areas. So Ken goes to medical school in 1974 at the University of Minnesota. Thanks for the shout out to the Gophers, Pam. In 1974, when Ken goes to medical school, there are 40 medical students at Mayo. The Mayo Medical School had opened in 72. There were 40 medical students at Duluth, a branch of the University of Minnesota. That had opened in 1972. And of course, the University of Minnesota main campus had roughly 180 kids where I went to school. And that had opened in the late 1800s as part of the land grant mission at the University of Minnesota. So that was about 260 medical students, 1974. The population of Minnesota in 1974 was 3.1 million. The population of Minnesota is 5.7 million now. There are no new medical students. It's been the same. So CentraCare is working with the University of Minnesota in a joint venture. We will start a new medical school in St. Cloud with a first class next year. And so we need to create educational opportunities to keep people in our communities by partnering with our educational institutions to make young folks who live in our communities want to stay and get an educational process in our communities and in work. 20% of America is rural. Only 4% of the students in medical school are from a rural environment, which means that there is an enormous challenge with kids in professional schools who come from a rural background to actually go into a professional school and then return home. So CentraCare is committed to building a medical school. We have 2 family practice residencies, one in St. Cloud and one in Wilmer. We have an additional training programs. We are starting 70 additional residency slots in OBGYN, general surgery, internal medicine, psychiatry, and pediatrics. So creating an educational context, and this requires a team effort. So we have hired a principal from a local school who networks with middle school and high school to make sure that we are sending the message to our public and private schools, charter schools. Please stay in don't go to the metro for an education. I'm not speaking ill of any college in the metro at all. I'm just saying we have to create a new dynamic. And this is not just about medicine. This is about all sorts of degrees and technical degrees. Our master electricians and plumbers in our organization make $110,000, $120,000, $130,000 a year. We need more of them. We need IT people. We need business people. We need all sorts of people, RNs, LPNs, nursing assistants. So what I'm getting at from an educational perspective is recruitment and retention, ongoing training and career opportunities, and third is a relentless commitment to education in new and different ways. One of the themes that you will hear from me is that in the past, industry segments were siloed. So for example, a healthcare institution was not into education. We have to be into education. I'm going to talk about housing in a bit. We're not a housing company, but we have to support housing initiatives to get workforce housing in our communities. Paynesville, a small rural community in the central Minnesota, they have a housing problem. That's our problem as well. So workforce is a major challenge for us and one we're spending a lot of time and energy and effort on. The second major thing we're working on is access. So healthcare is a weird dynamic in that it is both high touch, I think all of us would agree that healthcare is very personal. It's really personal, and it's high tech. To think that healthcare will be high touch universally in the future is mistaken. And to think that we're all going to flood to iPads for care is mistaken as well. We will always be a blended with more and more technology solutions. So how do we increase access, whether it's face-to-face or using digital modalities? There is a paradigm shift, I think, going on as we look at how healthcare is delivered. My mother lost her job in 1970 when our local hospital in Forest City, Iowa closed. It has been historically said that good health care in a rural town in America means there must be a hospital. You with me? That is no longer true. There's a lot of challenges to having hospitals in some small towns. Maybe the proximity to another larger town. It may be the ability to recruit. I will give another example. There was one family practice doctor in my small town, and when that gentleman left in the 70s, which caused the hospital to close, they were unable to recruit because new professionals don't want to be in solo practice anymore. They don't want to be Dr. Marcus Welby, MD, and do OB one day and do a surgery the next day and see a clinic the next day and do pediatrics the next day. Young folks coming out of training want to be in what we call a group practice, where they have benefits, they have scheduled time off, work-life balance is better. Their spouse might be a professional. And so the notion of how we provide care in a rural organization in rural settings is changing. It is a combination of both high touch and high tech, involving a team of workers, RNs, advanced practice providers, physicians, respiratory therapists, physical therapists, etc. So the static definition of care has changed a lot. Part of that process with high touch and high tech is to make sure that we're following quality. There has been a lot of controversy about closing OB programs in small rural towns. We are learning more and more about what high quality healthcare is. And this is not universally true, but there's some generalities. The fewer procedures you do, the higher the risk it is for the patient. So if you are doing only 30 of X, and let's call that an emergency C-section in a year, you need to ask yourself, is this really a vital community asset? Or can I partner with somebody that's 20 miles away or 25 miles away that does more to make it safer for the mother and the baby? I don't have an answer, but I'm saying these are the kinds of questions we have to answer. So high touch and high tech, and the definition of quality healthcare is changing and how we access healthcare. So as I said, second thing is access. We need to manage generational perspectives. I suspect that the younger folks on our call, and I'll pick on Pam because I can see her face, you would much rather use an iPad to get a prescription for otitis media for a little kid if you have one, rather than take a half a day off of work, go sit in some doctor's office and waste your time and then worry about that. And so we are changing the modality. There are drones that are being developed to deliver medications and other healthcare equipment to your doorstep using a drone. And so we got to recognize that we are committed to high quality healthcare. But if the definition of healthcare quality was based on previous paradigms, that will change. It should not change our persistence and pursuit of higher quality. And in fact, healthcare in America continues to get better. It's just that it's going to be delivered differently. So how do we manage the dynamic tension between high touch and high tech? Because it is personal. The other technological challenges we see is the burgeoning of, for example, of artificial intelligence and chat GPT. We have Mayo, Jim is really involved in this, and we partner with Mayo on a lot of things. There are some really foundationally cool things about AI, and there are some remarkably scary things about AI. We currently have 6 programs running in the background. We provide our electronic health record to 27 hospitals in the outstate Minnesota. And there are a lot of cool things, but clearly technological advancements will drive a lot of change in healthcare. So how do we strike that balance between the scary part of AI and the really helpful part of AI and balance high touch and high tech? So number one, workforce. Number two, improved access. Number three, improved quality. There is a sad and inconvenient truth that patients in rural Minnesota have worse outcomes. I'll say it again. Rural Minnesotans have, in general, worse outcomes than those folks that live in metro. And there are a lot of them, particularly in major disease categories, cardiac, neurological, and oncology or cancer. And there are a lot of different reasons for that. It's kind of beyond the scope of our conversation, but just take my word that there is a difference in outcomes in general for rural Minnesotans. We need to change the way we view our treatment of some of these diseases and have a broader holistic approach by working together with partners, with churches. In an aging population, how we work with our senior citizens programs. We need to work better with our employers. Remember that 80% of health and health care outcomes does not happen in a doctor's office or a clinic or a hospital. It happens at home and it happens at work. There are a lot of environmental issues, a lot of societal issues, socioeconomic issues. I will just give you a couple of statistics. Half of the kids in the 43 counties that we serve are on free or reduced lunch for school. That is a significant issue, not only related to funding schools, but how kids learn, but also from a nutritional perspective, right? So how do we understand the holistic approach we need to have our communities be healthier? We need to work aggressively. About 50% of our kids come from a single parent family. I'm not trying to make a political or social judgment. I'm just saying that we need to figure out how to and what to do differently with our partners to make sure that kids grow up in a wholesome environment. We started a child abuse center about 5-6 years ago. We see nearly 500 kids a year now with significant issues related to child abuse. And this is a challenge. And so improving our quality will require a team effort. This is not just on healthcare. We have to do our part. Absolutely. We have to look at every mistake that we make. We do make mistakes, but it will require really a team effort in how we look at it. Same thing can be said for mental health. Mental health tends to be the football that everybody likes to kick around, but it is a significant issue, whether it's violence in our communities or violence against kids. And there are all sorts of issues related to that. The number one killer of kids in America now is guns. And I'm not trying to make a political statement on guns. I grew up hunting. I still hunt. I like guns. But when you recognize that cancer is no longer the number one killer in kids, but guns are, what are we going to do differently? The same issue, I'm not trying to make a political statement, is climate change. The incidence of respiratory diseases in kids is climbing exponentially. And the incidence of asthma is climbing exponentially in older citizens. So how do we understand, without taking a political stance, and how do we come together to say, how do we make our rural lives healthier in all aspects? Socioeconomics, the income disparities cause folks to delay care or not get care because they don't have access, or they choose the wrong type of care. Roughly 50% of the patients in our emergency rooms don't belong there. They belong somewhere else where they get better care. It might be in a clinic, it might be in an urgency center, it might be with a telephone call, it could be maybe a nurse visit at home, all sorts of things. But how do we work with our patients, employers, and communities to really create a holistic approach? The last thing that I will comment on with the other 5 minutes here before we take questions is the fourth area that I want to talk about, and that's Main Street. Main Street in rural America is struggling in some towns. If you're a county seat or you have some robust businesses, you will be spared some of the challenges related to Main Street. My Main Street in my small town in Iowa is deserted. I'll just give you another factoid. I spend a lot of time looking at data because I think data helps inform the work that we do. Last year in America was another important year. Americans bought more stuff online than they did in a store. Americans bought more stuff, and all of you did. I'm not blaming anybody. I'm just saying markets win. And the challenge is that online marketing and selling favors very large distributors and takes away from what I would call smaller Main Street merchants. We can't fight that, but we have to understand the consequences. So how do we reinvest in Main Street America in a different way? And I think a lot of that involves a lot of different approaches. You're well aware that the number of farm workers has gone down. Farms are bigger. They're very complex technologically. As I said, my kids are in the John Deere business. The technology that they have on their stuff is unbelievable. The farms are much bigger. There are fewer kids. And so how do we understand the role of agriculture in the 21st century and what it does for our rural economies? How do we understand the housing needs? I mentioned that. Childcare is really important. And I'll mention briefly this notion of what I call, it's not precisely accurate, but it'll give you an idea what I'm getting about. That's brain drain. A lot of our young kids that grew up in our smaller towns are going to the metro. It might be for school, it might be for a job opportunity, it might be for a partner, it could be for a lot of reasons. Maybe they like the Vikings and want to go to the Vikings game. It's complicated. But how do we together, working with Main Street and our community leaders, have a sense of optimism? I go back to when I was a kid growing up. Every time there was a bond issue in my small town in Iowa, it passed every time. And we had a cool school. I mean, there were like 70 kids in my high school class. We had football, we had basketball, we had baseball, we had sports, we had theater, we had band, we had everything. And there was a commitment. Granted, there were a lot of young kids and the dynamics were different in the 50s. But how do we create a new dynamic in the 21st century where our communities come together and leaders come together to say, we are going to take a different approach? And so that it yields to one of the takeaways is that in a polarized environment that we're in currently in America, how do we find ways to work together? We are in a polarized environment. I'm not blaming anybody. I am just saying polarization prevents us from moving forward. So one of my key goals in my organization is to find out ways to say, how can we work together, whether it's related to education, workforce, access, or quality. And I would finish with this. We need to accept reality. Today and tomorrow is not going to be the same as the 50s. As much as I loved my small town, we got to accept reality. And I'm a big believer in saying that at least two things can be true at the same time. We have to accept reality, and we must have relentless optimism. We have to do more, faster, together. And that means investing, and that means collaborating. Admiring the problem does not make it better. So that was a very high level thing. I'm not exactly certain what you were expecting, but that's what you got. As I said, CentraCare is committed to making rural life healthier. We're focusing on workforce, including education. We're working on access. We're working on quality. And we're working on a collaborative approach using mainstream and our business partners to get vitality back into our communities. And Pam, I'll turn it back to you and manage the last half hour however you want to.
Thank you so much, Dr. Holmen. I was taking a lot of notes here, and honestly, like some of the things you're saying are the exact conversations I have with my in-laws who are the city side and I'm the rural side, and trying to explain why we should be recruiting people to live in rural Minnesota. So I might send them this recording afterwards as well. Are you willing to take any questions if people have them?
Absolutely. And by the way, nobody can offend me. I am from a small town in Iowa. And so if anybody has a disagreement or whatever, we can have any kind of conversation you want. And so thank you very much.
This is Jim Checkle, and if you don't mind, I'd like to go first on 3 things we're doing in my area.
Sure.
Okay, so the first thing is we were approached by Mayo Medical School to offer a training class for some of their students. The students had requested rural training. And so Ruth Merrick, Cindy Christensen, and I have been working with the Mayo Medical School. And so what we did was we hosted a program where we had them come out and spend about an hour and a half with the Dodge Center ambulance service to learn about what's going on with ambulance issues and the shortages and everything involved with that. They then came out to my farm for a couple hours to find out what an auger was and what diseases and things that they may be exposed to. And somebody just posted, where do I live? I live in Casson, so Southeast Minnesota. And so then the third part was then Ruth and Cynthia and I met with the students at our local town hall and discussed, had a panel discussion of all the issues that we see facing problems in rural Minnesota, including rural mental health and safety and things like that, rural care, just to give the students a taste for what's going on. And that was a fantastic program. And Farm Bureau has now put money toward that so this continues to be a program for all medical school students. And I would, when you talk about getting a medical school going, I would see or really encourage that. It is just a phenomenal program. And Ruth is with the serves up to the state office, and she may be able to provide you with information or contact information as far as what we did and give you kind of a general overview. The second thing is the Casson Clinic, which is a clinic for Mayo. They wanted to have where people could be community representatives. And so they went to all the local towns and asked them, do you have someone that could serve on a board, a discussion panel, that type of thing? And I just happened to be walking by the clinic when this discussion was going on. And I said, well, what about the people that live in rural Dodge County? And they're, well, who do you mean? And I said, well, like the farmers and the rural residents and things like that. And they said, oh, we hadn't thought about that. So you're on our discussion panel. So I'm just finishing my 9th year of my 4-year commitment to that. And, but it's amazing how even the people that live in these small towns aren't aware of a lot of the issues that we're facing out on, the rural population in our town or in our county. And we have been able to introduce a lot of things to Mayo that they were not even aware of, including a discussion a few years ago on rural mental health, which Mayo then set up a program and has been quite successful. So that's something else that has been very positive in our area. The third thing is that there's a group of us, one person from every town, and myself as representing rural Dodge County have established a community foundation. And so we're getting money from the different industries and grant money and things, and we're using that money to establish a ambulance or an EMT, EMR program at Triton School. And so we've got now where students can get certified, and the ambulance crew is actually donating some of their time to get the program going and things like that. But it's actually, we're getting this established, and there are a couple other schools in the state that are doing this, but we're getting this established in Dodge County. And then we've also gone to some of the other schools and they've said, well, if we can show that this works at Triton, then we can get students maybe interested in Casson Manorville, for example, or Hayfield. And so our hope is to get students trained to the point when they graduate, they are an EMT or EMR or things like that and been certified. So then we have the potential pool for future people to serve for these ambulances where we can't get staffing.
Great points, Jim. And those are all things that we have been doing as well. Our medical students will all have a rural focus and have their training program, and our residents as well in outstate Minnesota. Holly Golden is on. Holly leads the CentraCare Foundation, and I think we're up to about $25 million. We have set up a foundation related to educational purposes, whether it's in all the different areas with support from our local businesses. It's been remarkable. And so I think this notion of how, Jim, as you described it, we're investing in solutions is great. So keep it up and expect more. Thank you.
A comment or a question came in on the chat that says, how do we move forward with keeping nursing homes open?
Nursing homes are both very personal. Remember when I said that healthcare is personal? Nursing homes are personal because that's where our loved ones are. And we have several demographic challenges that we must understand. One, more and more older folks would rather age in place. That's one of the reasons why we're having a housing problem. But when they need to move to a nursing home, their needs are significant. Does that make sense? So the demands on the nursing home or the senior program continue to escalate. So the demand is quite significant. Number two is that the staff for a nursing home, for the most part, would be nursing assistants or CNAs on the lower income level and the lower educational level of the workforce. They might be 18, 19, 20, 22-year-olds and at the making 16, 17, $18 an hour or something. And so what happens is there's a lot of turnover. So not only is there a shortage of folks to work in a nursing home, there's a lot of turnover. Thirdly, is if you want to pay higher wages, the economics from a revenue perspective for nursing homes needs to change. Much of the revenue structure around nursing homes is controlled by the state, and there is an underfunding of nursing homes. Again, it gets into the politics of how we manage a state budget, as well as that if we depend on self-pay for nursing home services, you can easily spend, pick a number, $10,000 a month on a seniors program for somebody that has significant disabilities. So I think it's important to recognize, number one, the demand is significant. Number two, the structure related to our workforce does not work well. We're desperately short-staffed. And third, the economics of nursing home make it very complicated. I'd mentioned a fourth. People are really concerned about this, but it also means that there's a lot of regulatory burden. And a lot of regulatory burden in some respects is good. It makes sure that your loved one is safe. On the other hand, a regulatory burden means that everybody has to function according to a long set of rules. And so the answer to the nursing home question is to acknowledge reality and come up with new solutions. It may be that we have to have more of what the Europeans would call a community health model, in which nursing home is not considered in its own silo. It's part of a broader perspective of keeping your community healthy. And how do we do that? Philanthropy has been an important part of keeping nursing homes afloat, but I suspect that will be insufficient. So I think the nursing home issue will continue to be a hot one in the decades to come. Until our demographic, I'm a boomer. I suspect a lot of folks when we're dead, the nursing home issues to some extent go away, simply come from a volume perspective. I hope that answered the question. That was from Carol, but happy to have any other comment on that. Requires a different look. The traditional way of looking at it will not cut it.
I have a question about addressing diversity in growing communities. A lot of people are leaving the metro for the suburban areas. How are you working to address those diverse groups as they are moving more rural outstate and addressing the care that they need?
Mm-hmm. So diversity in my mind means lots of different things. And I'll focus on some of the issues that I know well in our care system. We have a large Amish population, about 2 communities of about 1,000 each. The needs of the Amish are fundamentally different than the needs of somebody that lives in Wilmer, Minnesota, because of their religious belief, horse and buggies and all that. And so we worked with them to understand what their needs were. And so we have created wraparound services. We actually have a nurse practitioner go there on Saturday mornings to see pregnant moms. And so they don't have to take their horse and buggy somewhere. We created a payment mechanism. As you know, they don't pay taxes and they don't take government subsidies. But we had to find out a way to buffer someone that had a $100,000 heart operation or somebody that had $50,000 cancer bill. And so we worked with them on the economics of healthcare. We have worked with them on vaccination. They have been vaccine hesitant. We've been working with them on that. So that'd be one example. Second example would be our Hispanic population. We have a large Hispanic population. And so we do health education in 13 languages and understanding. We have nurses in some of the large meatpacking plants in our community. We have, I think, 2 or 3 of the largest meatpacking plants in the country. And so we make sure that we are providing care where they need it in the modality that they can understand and accept. And their needs are different. Likewise, the Somali population. whether it's language again or religion, come at it from a different perspective. One of the challenges in today's, I mean, this will sound political, but believe me, it is not political, is that for some folks, the word diversity has a negative connotation. And for some people, diversity is really important to make sure that we improve healthcare outcomes in an increasingly diverse America. And so how do we step back from the precipice of arguing about diversity and understand, I think that nearly everybody I know, whether they're Muslim or Amish or Christian or Jewish or Catholic or agnostic, want to live a full, rich life. I fundamentally believe that with my heart. And so the question then is, how do we understand diversity at a personal level, and then also wrap around our structures and services to make sure that we're delivering what's needed in the face of a challenging economic and political environment? Boy, I don't know, Rachel, did I make sense at all?
Yes, it did. Thank you.
We have to do more. The healthcare outcomes in our diverse populations. If you take a poor Hispanic family, their healthcare outcomes are abysmal, just awful, for a lot of reasons. So there's more that we can do there. Other comments or questions?
So I think some of the things that Jim mentioned that he's doing in his community are a really great brainstorming start for what someone who might be passionate about this topic could do in their own area, but it also might seem like really overwhelming. So if our members were going to go out and do one thing to help with any of the issues that you talked about, where is the first place you would recommend they start?
So I would, I'm not a big believer in task forces, because task forces take 5 years just to figure out who's on the task force. I am a strong proponent of getting leaders together and saying, we're going to work on this problem. So acknowledge reality and then work on a process to deliver successful strategies and then implement them strategies in what I would call more of an entrepreneurial fashion rather than a task force perspective. Jim, I'm gonna pick on you for a minute because you mentioned a hot topic, and that's EMT in rural Minnesota. EMT is really a challenge, and it really reflects a confluence of several things. So historically, in rural Minnesota, EMT was provided by volunteers, right? They might be volunteer police or fire or whatever. And the challenge is that when you have fewer young people, the number of volunteers is less. So it's a workforce issue. Number two, it's a training issue. And number three, it's a compensation issue. And so we have to come up with different creative solutions. And as you know, coming up with creative solutions in the context of those acknowledging reality can be a challenge, but I do think it's solvable. But as long as I'm being reasonably straightforward, I'm gonna mention one other thing that gets in the way of rural health becoming healthier. How many of you value your independence as a small town? Think about that in your head. If you want to stay independent as a small town, that's going to be a challenge. I am not saying that you don't have a say in what's going on. I'm not saying that your voice is important, but I'm saying we need a lot more collaboration, a lot more collaboration. And I'm using EMT as a good example. So EMT services arranged, their laws related to this might be by county or by the state in terms of the geography of a coverage. And if let's say that somebody runs the ambulance service, let's say it's Smith County, and they're convinced they can do it on their own, when in point of fact they might need to partner with Mayo One, for example. I just threw that out there, Jim. But the county is committed to staying independent. And so I think we all have to check our biases at the door when we start acknowledging reality. As I mentioned, my mom lost her job and my small hospital is closed in Iowa because folks didn't acknowledge reality. Let's acknowledge reality, create processes for voices to be heard, and recognize that we need to collaborate more and work together more, better, faster.
Well, if I can comment on your comments.
Yeah.
So what we have done is we've started a group of people and we looked at what the costs are per ambulance. And so like the townships do not have taxing authority,
Correct.
but the cities do. And so we figured out what it costs per resident of the county for the ambulance service. And we're going to have, the cities are putting $65 per residency on, or per resident on individuals in town. In the townships, we figured out how many people live in our township, and we've raised our levy, the amount, for $65 per person. And the idea being that we may, if Medicare, Medicaid, whatever, changes their funding, that may go up or it may go down. We're still working on getting that taken care of. But we have, one of the things we've been talking to the ambulance services and the fire department services is the same reality of what you're saying. Dodge County has 3 ambulances. They're going to end up with 1. That's the reality of it, you know. And so how do we address this?
Jim, you're spot on, because now we get into the confluence of business models, compensation, and workforce. And we just have to, as I said, acknowledge reality, but commit to working together. There is a solution there. I'm confident of that. Look what America's been through. I am very confident and bullish about America, but we have to think differently. Carol said about video visits be a great place to start with patient healthcare to be more inclusive. The answer is yes and no. I believe that more and more healthcare will be technology enabled. I mean, I don't know how many of you are wearing an Apple Watch that can do all sorts of things, but there are boatloads of apps being developed. Apple is working on an ultrasound app for its phone. So you take your phone and put it over your chest and it'll do an ultrasound of your heart for you. There's a lot of technology coming. So I think more and more will be digital, but we have 2 challenges. One is that people still have a perspective around healthcare as personal. And the second we have is what I will call the user reluctance. We have a 92-year-old lady with chronic congestive heart failure who Skypes every week with her nurse practitioner. She carries her iPad with and shows the scale as she steps on it, and it's fabulous. We have 65-year-old white males who refuse to sign up for MyChart because they don't buy technology, and they have a flip phone. I'm not blaming anybody. I'm just saying that we have to manage that diversity. I think that the generational dynamic with the young folks in Pam and Rachel's age, they are very technological adept, whereas I will call this the silver sneaker crowd is not as technologically adept. But certainly, Carol, video visits are an important part of creating access in all sorts of ways. Absolutely. And by the way, it's more cost effective.
Can I add on to that though?
Yeah.
What about the self-diagnosis? I always think the doomsdayers who might do that ultrasound and they do it and then they Google and they're trying to, how are you combating that kind of reaction to those technological advances, or people trying to be able to self-diagnose before they go seek help?
What's that old phrase? An individual who acts as her own lawyer has a fool for a client. That said, I do like the proliferation of medical data on the internet. The challenge with social media and the internet is that X% of it is garbage. We can see that in lots of different ways. So one of the things I do appreciate about patients when they come in, and let's say that you have lupus, an autoimmune disease. I love it when patients come in and say, you know what, I think I got lupus and I've read about it, and here's what that's an educated population is better, no matter where they get it from. The challenge, of course, is there's a lot of people selling quack stuff on the internet, wear a copper bracelet or take this drug or eat cauliflower 95 times a day. So I'm positive that we will have more and more education, but there still needs to be some, let's call it a quarterback care management process to help say this is good information and this is not so good information. Access to internet from Holly. Yeah. So CentraCare partnered with Mayo and a couple other companies last fall as part of the infrastructure bill that was passed to improve broadband access, about $100 million for the state of Minnesota, to make sure that all of our counties. So I live in a rural Cold Spring, Minnesota, and so my broadband access download is like 6.8 megabits per second, which is terrible. Whereas I can go a quarter of a mile and it's 58 megabits per second. And so if we're going to indeed take advantage of technology for healthcare, and by the way, it's not just healthcare, it's farming. All the tractors nowadays all have internet programs that tell their seed yield and production per acre per square foot. And so we need it for all industry. We need to have rapid, easily accessible broadband coverage throughout Minnesota, and we don't. It is coming, but as true of all things, it takes a while to get going because we have a lot of broadband carriers in Minnesota, and right now they're all kind of squabbling about who does what. But we clearly need to have broadband coverage universally present through all parts of Minnesota. I don't care where you live. Because we want more people to live in outstate Minnesota who might work in a gig economy with an employer in New York. We have probably 3,000 or 4,000 workers that work from home. We have now employees in 26 states. And I'd like to make a convincing argument to somebody that lives in New York. Why don't you come to Minnesota, rural Minnesota, live on a lake. Schools are great, minimal crime, no traffic, hang out with cool people, go to play bingo, have a meat raffle, go hunting, go fishing. I just think we have to change the paradigm rather than have it be the little engine that couldn't. I would say let's be the little engine that could. Anything else?
Yeah, you mentioned something about, did you mention chart span at all? Chart span, I'm 80 years old and my the clinic is wanting me to register for that. And they said the Medicare pays for it, insurance pays for it, and all that sort of thing. I was just curious in the rural area if something like this was a good thing, because I question the cost of it and insurance being charged for it.
I am not familiar with ChartScan. What does ChartScan do, Roger? What's the application for?
ChartSpan says it gives you 24/7 nurse line, assigned personnel care coordinator, help requesting health records, prescription refill assistance, personalized care plan and goals, and help with transportation, all those kinds of things.
So I will answer your question broadly. And so there are a lot of startup companies in what we would call a digital space that is helping to manage personal healthcare needs in a more cost-effective and probably more direct interactive fashion through an iPhone or iPad. They are for-profit companies. I'm not saying they're bad. I am just saying that they have a designed business model in play. And indeed, payers will pay for some of them or all of it, depending on the cost and the structure and what it provides. These are technology-driven companies. Indeed, it may be good for you, Roger. I couldn't I'm not trying to cast aspersions on them. Indeed, it might be good for you. I think you'd have to try it. But I think the principle is, number one, a lot of startups are entering this space to help provide more immediate coordinated care in a more accessible format. And number two, the government and health plans, depending on that plan, may or may not pick up part of it. I would say try it and see if it works. If it works, good for you. That's excellent.
Thank you. Because I'm, like I said, when they mention that Medicare and so on is going to pay for it, I question it right away.
I might, this is going to go sideways a bit, but about 80 from an observational perspective, probably about 85% of healthcare in Minnesota is provided by one of 6 large systems: Mayo, Health Partners, Allina, Fairview / the University, Children's, CentraCare, and Essentia. And we do not use that because we have developed our own in-house models of virtual care. Those communities that are not a part of a larger system are looking for solutions. And so indeed, that is why those options are available. Hope that made sense for you, Roger.
Yes, it does. Thank you.
Dr. Holmen, with the decreasing population on the young end, where in 15 to 20 years we'll have less people going into the workforce, while having more people who need that really intensive care in their older age, how can we as community members support, or who do we need to talk to, who do we need to encourage to get more people going into those careers and having support for that in our own communities so that we aren't getting a shortage in 15 to 20 years? How can we work ahead and try to support that now?
I think there are some broad themes that number one, how do we make people understand that living and working in rural Minnesota is a cool thing rather than a negative thing? And that requires a team effort. I love my community. Heck, I go down Main Street and I know folks, they say, "Hi, Ken. You know, this is cool. You're not worried about all sorts of stuff." Somebody has a problem, everybody helps out, right? It's a great sense of we have to sell our community. And so that's one thing. And so how do we sell it together? And that requires healthcare, it requires farming, it requires Main Street, it requires our churches. We have to figure out what pulls us together, not what drives us apart. That's one thing. Number two, I think we have to reach out earlier to our kids who are leaving our communities and say, come back home, not because dad told you to or mom wants you to, but because it's a great life for you and your family. And that requires a collaborative effort by all of us. Thirdly, I think it takes a village. I think it was George Bush talked about 1,000 lights. I'm kind of aging myself here. We have allowed our life to become very siloed. And we instead have to have a sense of community. So, for example, for aging seniors, have we rather than nursing homes are important, by the way, but how do we create a village around our nursing homes to help address some of the workforce issues? How do we have more volunteers? Maybe we need to start a foundation in our communities to support an aging population. I don't know, but you got to be willing to think differently, to say, how do we create a robust environment that achieves, number one, getting kids to stay here or more people to move in. Number two, provide those wraparound services to allow people to stay and celebrate our communities longer. And three, be a successful and sustainable business model. And that means people working together, not everybody worrying about this or that from an individual silo perspective. You got to think differently. And actually, that's the way. So I hate to admit it, but I am Norwegian. Fine, I'm proud of being Norwegian. If you go to Norway, much of their social infrastructure is based on the sense of community. And we have somewhat lost that in America, and I think that we can re-find it.
I'm going to hop on here. I'm Ruth Merrick. I'm the foundation director, and I have worked with Jim and Cynthia a lot on the Mayo and the medical student program. The one thing that I think has been the best outcome of the work that has been happening down there is that we are teaching these young medical students or giving them the opportunity to understand farm culture and the way that farmers think and act and make decisions. An example is we had one person say, I put a pitchfork through the calf of my calf, and I wasn't sure if I should go to the doctor or not. And the fact that they have to understand that, you know, they still have cattle to milk and they still have these things to do. And oftentimes they'll put their livestock or their farm ahead of their own self-care. And I compliment you because of your deep understanding of farm culture and the cultures of rural communities. And I compliment the work that Jim's been doing with the Mayo medical students, because we are trying to teach a demographic of people a culture that they don't understand yet. And if CentraCare or if there's other Farm Bureau members on this call or other individuals want to understand and learn what we are doing, please reach out to Jim or I, because we are happy to share what we're doing. Our investment into that program from the foundation is to expand that program and give these medical students opportunities where they can have conversations with farmers at different events within Farm Bureau, to continue that learning process. So, and don't beat yourself too much up about being from Iowa. I am a Northeast Iowa girl myself, born and raised in Riceville, just down the Highway 9 from you.
Yep. Yeah. So our focus on the medical school, I think you're getting into something really important, is that if we grow our own, we have a chance to keep our own. So if you go to our website, we have a singular focus on rural healthcare. We have our admissions team will have a focus on picking folks for medical school who have an interest in rural healthcare. We will ask them that specifically. Our training programs are focused. As I said, we have two family medicine residencies. All of them last year, all the graduates stayed in outstate Minnesota. So we will have a singular focus on rural healthcare. And it's a very unique model, and we're getting some attention nationally from other states on a rural focus. As I said, 20% of the population of America lives in a rural environments. And so how do we reinvest in a rural perspective, Ruth? And I think you and Jim both mentioned some great examples of how you're doing that in your geography, and we just need more and more of it.
Dr. Holmen, thank you so much for all of your time today. This is just great information and will be very useful in the days and months and years to come as we continue to talk about this issue and how it's impacting our rural communities across the state. So thank you very much.
And I want to give a shout out and thanks our many members of our communities. I see Holly's on the thing. We're over 25 million in donations from rural folks to support a rural medical school. So it can be done, and we're very thankful for all the great support that we've had so far. But thanks for the opportunity. My objective was not to offend anybody. My objective was to have a frank conversation and recognize we're all in the same boat.
Yes, thank you. And thank you to everybody who was able to join us today. Our next call will be on August 15th, and very fittingly to this conversation, we will be talking about labor and what that looks like in rural Minnesota across the state. So we hope to see you then.
Thank you.